Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
Today's podcast will focus on tardive dyskinesia, and I'm honored to be joined by Dr. Leslie Citrome, Dr. Juhi Jimenez-Shahed, and Dr. Adolfo Ramirez-Zamora. Dr. Citrome, if you could take a minute to introduce yourself.
Certainly. I'm Dr. Citrome. I'm a clinical professor of psychiatry and behavioral sciences at New York Medical College in Valhalla, New York, and adjunct professor of psychiatry and behavioral sciences at the Feinberg Northwestern School of Medicine in Chicago, Illinois.
Thank you. Dr. Jimenez-Shahed.
Hi, yes, I'm Juhi Jimenez-Shahed. I am a movement disorders neurologist. I practice at the Icahn School of Medicine at Mount Sinai in New York City.
Thank you. And Dr. Ramirez-Zamora.
Thank you. I'm Adolfo Ramirez-Zamora. I'm a professor of neurology at the University of Florida and the division chief here at the Normal Fixel Institute for Neurological Diseases.
Thank you. And thank you again to all three of you for joining us today and to take some time to have some discussion on this important topic. So our topic for today's call is a discussion on the differential diagnosis of movement disorders. And I wanted to throw out a couple of questions to the group to get things started. I wanted to start if we could have a discussion on how clinicians can accurately differentiate amongst movement disorders, including identifying patients with tardive dyskinesia earlier versus other drug-induced movement disorders, because I know, as we've discussed individually with all of you, early intervention and identification is really important to assist with potential positive outcomes. And so what are some of the key sort of diagnostic challenges and how to overcome those when you are considering the differential diagnosis of movement disorders? And I guess if Dr. Jimenez-Shahed, if you'd like to start.
Sure. I think, tardive dyskinesia for me is the type of diagnosis that can be made when you recognize a certain pattern of involuntary movements and question the association with exposure to a dopamine receptor blocking medication. So I think it's a combination of having familiarity with the condition, the fact that it exists, the different phenomenologies that it can present with, and then knowing to sort of ask for that history of medication exposure. So I think the timeline for development of the abnormal movement is also quite important. There are certain movement disorders that can occur in the context of exposure that occur relatively soon after the exposure to the medication. So let's say somebody started a neuroleptic medication and started developing some dystonic episodes, something like maybe an oculogyrate crisis or a cervical dystonia, something of that nature. You may be more inclined to, or that would be most consistent with an acute dystonic reaction, and could be very easily mitigated by eliminating the causative medication. Versus a movement disorder that occurs after a longer period of time of exposure. Typically with tardive dyskinesia, we're talking about at least 2 or 3 months, depending on which criteria you use for that exposure. But having at least been exposed to the medication for that long, but sometimes occurring even after a number of years, or even after already discontinuing the medication, perhaps for some other reason. So I think understanding that sort of time course and the different ways that it can present is also important. And then lastly, probably one of the other types of movements that can occur in the context of neuroleptic exposure is like a drug-induced Parkinsonism, which again is not necessarily going to present in the very acute exposure phase, but can present after having been on these medications for a period of time. The key difference here is that it's a tremor and not a dyskinesia or a dystonia, and recognizing the difference between that is certainly the sort of first step. But tremor is usually also accompanied by some other features, including things like rigidity and also bradykinesia, perhaps also some gait changes. All of these are things that should be looked for, and then certainly ask about the exposure to the neuroleptic. A key difference here is the treatment approach, which again, drug-induced Parkinsonism can improve and resolve with discontinuation of the offending agent. So it's very important to be able to make make this differential diagnosis to appropriately identify the treatment that is appropriate for the patient.
Certainly, if I could add to some of the challenges, is that why would you care to try to characterize this movement better? Well, we care because we can really dictate treatment depending on the different phases of tardive dyskinesia. I think that when you're seeing or we're faced with these movements, it's very easy to say, well, this is dyskinesia, which simply means an hyperkinetic involuntary movement, but the different types could really, the approach to treatment really varies depending on the different forms. Just like Dr. Jimenez said, if you develop Parkinsonism as part of the exposure to a dopamine blocking agent, it's almost impossible to clinically distinguish neurodegenerative Parkinsonism from a drug-induced Parkinsonism. In general, we tend to tell our residents and our fellows that if you see more than 2 or 3 phenomenologies within the same patient, you should always suspect a drug exposure until proven otherwise. In other words, if you have dystonia, chorea, if you have abnormal stereotypies, especially in the craniofacial musculature in the face, you should consider exposure and you should investigate that as much as you can. But recognizing the different semiologies and phenotypes that can occur when you're exposed to these drugs is really important when you're trying to select treatment, because if you have a tremor that is actually induced by some of the treatments that are for the psychiatric treatments, you may you make the problem worse as you with certain approaches. So it's really, really key. It may be hard, especially early on. It's not really obvious sometimes, but as time goes on, you can develop a strategy to try to separate the different forms and also establish the specific treatments.
And I think it's probably worth mentioning that some of these can coexist. I think that's what you were trying to sort of get at there. And it is possible for somebody to have coexisting tremor and which is, like a drug-induced tremor, drug-induced Parkinsonism, alongside sort of a more traditional tardive syndrome, like a orobuccolingual stereotypy. And in situations like that, it can be a challenge both in identifying the primary issue, but maybe there isn't, maybe there really are too, and choosing the appropriate treatment approach in that regard. And so identification is always the first step.
So in the psychiatric world, we're faced with a variety of different drug-induced movement disorders. And for a long time, it was not considered important to distinguish amongst them because you just throw some benztropine at them and hopefully that will work. And that's been kind of what's been done for so many years. The availability of drugs specifically indicated for tardive dyskinesia has changed that and has led us to actually promote the idea that these are very different, and they are very different, requiring very different approaches. So, for example, drug-induced Parkinsonism has for years been addressed by anticholinergic agents such as benztropine or trihexyphenidyl, and that seems to work. But we have an alternative now that we can talk about, amantadine. Akathisia has been unsuccessfully addressed with anticholinergics, and we do have a better way of addressing akathisia, and that's with propranolol. And acute dystonic reactions we want to avoid, and we can do that by using second-generation antipsychotics, and should we see it, we use an anticholinergic. So with TD, we'll use a VMAT2 inhibitor because that will work. A VMAT2 inhibitor will not work for drug-induced Parkinsonism, and in fact may make it worse. And anticholinergics don't work for TD. In fact, it may make it worse. So treatment for one may worsen the other. And that's really the selling point in the educational process of the importance of a differential diagnosis, because not only are the treatments different, the treatments may actually make something worse. So what to do? Make an accurate differential diagnosis based on the phenomenology. Also, if you've had a therapeutic misadventure and someone got worse, well, rethink your diagnosis. And then there's another clue. If you increase the dose of the antipsychotic, the tardive dyskinesia looks better. It's called masking. And in the old days, again, with using haloperidol, we would do that. We had no other choice. We would increase the dose of the haloperidol and the TD would look better, at least temporarily. If you give an anticholinergic to someone with TD, it'll make it worse. If you give more antipsychotic, it makes it better. So that's a clue. Someone with drug-induced Parkinsonism, they'll get better with benztropine, perhaps get worse with a VMAT2 inhibitor. And certainly when you decrease the dose, they'll get better. You decrease the dose in someone with TD, they won't get better. In fact, you may see more movements, at least temporarily. So the interaction between the different drugs that are prescribed and the phenomenology can also give us some additional clues. Ultimately, it'll take some time to sort this out, but ultimately we will straighten it out. And the goal here is for the long haul to give the correct treatment. Now, it was mentioned towards the end about having both at the same time, and this is not uncommon, and perhaps we'll have time to discuss that a little later in this conversation.
Now, can you talk, and all three of you sort of alluded to, a lot of the different symptoms that you may see clinically. I'm wondering about the role of sort of the patient and their caregiver or their caregiver in this, because again, there's a lot that you're trying to tease out in terms of symptoms and understanding, the what and the when and the sort of complexities of that. How much of a role does sort of patient education, caregiver education play in helping navigate this differential diagnosis? And how do you address that? Sort of, is it at diagnosis, or is it at when, medication is initiated, or further down the road? So I guess, how do you incorporate the patient and their caregiver in navigating this differential diagnosis?
Well, the caregiver is often the one who's making the complaint because they're saying my son, daughter, husband, wife is moving their mouth in a very strange way, and people are staring at us and pointing fingers at us, and it's very uncomfortable socially. And but my son, daughter, husband, wife doesn't realize they're doing that. And when I tell them to stop, they said, "What do you mean stop?" So there's an unawareness of these movements with many people with tardive dyskinesia. And the caregiver is at the forefront of promoting, got to do something about this. And that's the implications of having, or consequences of having TD. It's not just a cosmetic movement disorder. It actually has impact on the functioning of that individual socially, within the home, and perhaps if they're working, it'll impact their work as well. So imagine you're a bank teller and you're moving your mouth on occasion. Occasionally the tongue sticks out. The customer will complain to the manager that someone just stuck out their tongue at me, and not, and the person doesn't even know that they're doing it. They get counseled that, you got to stop doing that. And so that has implications at work as well. So very often is other people notice it, and that drives treatment.
I think also historically, obviously we all want to provide and strive to provide patient-centric care, but I think, having the dual input of both the patient and the caregiver in terms of recognizing the time course of the symptom onset is also another strategy to try to pinpoint, when you're trying to make the actual diagnosis. So I think definitely seeking that collateral from other caregivers or family members, et cetera, is helpful in establishing the relationship to potentially the dopamine receptor blocking medication.
In addition, you may not see the movement in the office so readily, even with the abnormal involuntary movement scale examination. So if the person living with the individual with TD can record on their phone the movement that they are just trying to describe verbally, that's a big help. And I've often done that, and it's very useful to see what kind of tremor are you talking about? Because they're not neurologists, they're not psychiatrists, so they don't know one tremor from the other, or from a tremor from a dyskinetic movement, but we can identify that readily on a video.
That's actually, it's interesting that you say that, because I use that strategy a lot, regardless of which type of movement disorder we're dealing with. A picture says, 1,000 words. So it's really illustrative if you can get that information. And I've had not only patients and family members sort of provide those types of videos, but also psychiatrists who are querying how to approach a particular patient that they have. I just say, next time the patient's in the office, please just take a short video and send it to me. And I'd be happy to just give you that quick curbside, because often with that information and that visual, we can assist in the management of the patient. I think the other part that I wanted to maybe bring up about this aspect of it is, we've seen in recent years that mental health has gone a lot to in the direction of telemedicine, and telemedicine is great for increasing access. But I think when telemedicine is further limited to just audio, then it becomes really hard, and the burden becomes on the clinician to really explore through questions, appropriate questions really, whether or not these abnormal movements exist. And so there are, perhaps different ways that one can go about asking about involuntary movements. Are there any things that you have noticed? Are there, limitations to speech or to swallowing, eating, chewing, things like that, that can maybe clue the clinician who may not be actually seeing the patient visually to the presence of tardive dyskinesia.
And I also really think that clinically, at times, some of these patients have prominent neuropsychiatric or neurobehavioral symptoms, and it is really hard for them to keep track of all the medication trials, the doses that were used, and also they are at times really apathetic, and they have a really hard time telling you the degree of functional impairment that's associated with the movements. And the caregivers are really wonderful, are helping with that. They're part of the treatment team that help us to collect additional information about exposure, duration of exposure, what else has been tried, and also to determine the severity of the symptoms and how are the symptoms impacting their quality of life, so we can make decisions about how to best treat them.
Thank you. I wanted to circle back also, and I know it was briefly mentioned that not necessarily these movement disorders may not necessarily be exclusive, and that there can be some overlap in terms of the presence of multiple things. I guess I was wondering if you could speak a little bit to how you may go about addressing that and teasing that out when discussing this with an individual patient, on understanding, whether this is just one thing or perhaps overlapping issues that may be present.
So this scenario is not unusual. Let's say you have someone on long-acting injectable haloperidol, and they've been on benztropine for a very long time because they're on long-acting injectable haloperidol, and it sort of manages their drug-induced Parkinsonism somewhat. And then all of a sudden, they start having jerky movements of their hands. This could occur 10 years later. Jerky movements of their hands, and they start sticking out their tongue, and they seem to be grimacing. And you have now someone with tardive dyskinesia and drug-induced Parkinsonism. And what do? They have both movement disorders at the same time. My approach here is to switch the long-acting injectable to a second-generation antipsychotic. This takes some time. Then observe what happened. I'm able to dial down the benztropine over a period of several weeks or months. That is necessary. See what happens. And sometimes the tardive dyskinesia is gone. Other times it's still there, but I'm ready to give the VMAT2 inhibitor for that residual movement disorder, just after optimizing their psychiatric medication. Now, some people are in a hurry and they want to take care of that TD right away, and you could start the VMAT2 right away, but you still need to do those other steps in order to optimize treatment.
Yeah, I think, for the drug-induced Parkinsonism part, where there's tremor, perhaps also a combination of bradykinesia, rigidity, especially if, you mentioned like switching to a second generation antipsychotic, but also consideration of a less potent dopamine receptor blocking medication that may also still be able to treat that person's psychiatric condition. But I agree with definitely, stabilizing, making that transition first and stabilizing the psychiatric status of that patient, or ensuring that it remains stable with that transition before initiating another agent is definitely reasonable.
Yeah, I completely agree. And if there are any concerns, I alluded to this briefly in the discussion, but if there are concerns about a patient having potentially neurodegenerative Parkinsonism on top of this, there are other things that we can do to try to establish the diagnosis. We can do dopamine scans to look for dopaminergic deficits in the striatum. We can do skin biopsies looking for the position of alpha-synuclein. now these days. So that has really changed and shifted the way that we treat patients, because if you think about it, it's not unreasonable to think that people that have exposure to dopamine blocking agents may have an increased risk of Parkinson's disease, classic Parkinson's. And then treatment decisions need to be really tailored to what the patient needs, and have discussions with the psychiatrist becomes even more critical, because we really have to see the patient as an individual that has progressive disorder with associated drug-induced movement disorders. What's the best way for us to combine efforts and potentially select a medication that will be best for that patient? And I think in those instances, it's really, really fruitful to work together with the psychiatry to try to figure out what's best for the patient. But that requires additional steps to ensure that we have the diagnosis and the phenotype as clear as possible.
Well, partnering with a movement disorder neurologist is desirable when cases are complex. There's another reason to consult a movement disorder neurologist, and this is the scenario where you're treating someone for their TD. They're a little older. You're treating them for their TD. They never had drug-induced Parkinsonism, never. You're treating them with a VMAT2 inhibitor, then slowly but surely they start developing a tremor of 3 to 6 cycles per second, and they seem to be moving a bit slower, and they seem to be a little rigid. And that's makes me want to get a consultation with a movement disorder neurologist to rule out Parkinson's disease, which was uncovered by exposure to the VMAT2 inhibitor. I can't order a DAT scan, but a neurologist can, and then we'll have a diagnosis that we need to address now that's different than drug-induced Parkinsonism.
Yeah, and actually, I think there is evidence that in individuals who have had prior multiple exposures to different neuroleptic medications and have had a prior history of drug-induced Parkinsonism, and maybe that was the reason that the neuroleptic was switched to a different agent at some point in time in the past, or the dose was reduced or something. Those are individuals who really want to have a high index of suspicion for now new development of idiopathic Parkinson's disease on top of their underlying either psychiatric disturbance or tardive dyskinesia when that history is present. And those are definitely the patients that I tend to recommend getting DAT scans or other tests, as Dr. Ramirez-Zamora was talking about, to establish whether that is the case, because that would really change my treatment approach to the patient.
Absolutely. You know, Parkinson's disease is not rare, and it's accompanied by neuropsychiatric manifestations as well. And they could somehow come into one's practice without one knowing that there is Parkinson's disease lurking there, and we uncover it. When we uncover it, we need to get some help with a movement disorder neurologist.
Perfect. Thank you so much. That was it was really interesting to hear different perspectives too, from clinicians who provide care from different circumstances. And
yeah, I'd like to add something specifically for psychiatrists who may be viewing this. It's easy enough for us to look and make a differential diagnosis. It's not too difficult. It's a matter of some practice and knowing what to look for. And I think it behooves us to treat these drug-induced movement disorders. If we run into some difficulties where it's not going away, then I would consult. And of course, I would consult if I think, oh, there's something serious going on, such as incipient Parkinson's disease. But otherwise, it's in my wheelhouse, and it can be taken care of in the psychiatrist's office.
Similarly, I always appreciate the opportunity to collaborate with a psychiatrist who recognizes that there is, a movement disorder present, and we can have those sort of collaborative conversations about how to approach the patient.
Yeah, I think those interactions can be really, really helpful, because there are other movement disorders that can occur with other psychiatric drugs as well. If someone is taking valproic acid, for example, or with certain antidepressants, where a drug-induced tremor, which is different of drug-induced Parkinsonism and the classic tremor that we see in Parkinson's disease, it will make a difference about how we decide to treat this patient best. So I think that for everyone listening, this establishing a good relationship with the psychiatry and the neurologist community and collaborating as much as possible. I know it's really hard. It's really hard to find time to talk or exchange emails, but if I could say, at least in certain cases, I think is really, really great. It's a great thing to do, and to really help us to determine what's the best treatment for that patient.
I wanted to thank you again, all three of you, for spending that time with us for this roundtable interview.